Hello and welcome. In this video, we are going to discuss the content for week 4. This week, we will be learning all about premature and small for date infants. These are your objectives for this week. You will read chapter 5. You will watch this video, our week 4 content video. You have your reading quiz, your weekly discussion, and you will also complete your research topic survey. So this is going to be found in our week 4 content on Brightspace. You can also find it in the quizzes tab on Brightspace. And this is a survey, and you are going to rank your topic choices for a research paper. Ultimately, I will assign you the topic, but we will go based on your most to least favorable preferences. Okay, so when we're talking about when babies are born, sometimes babies can be born small for their gestational age. So when babies are considered that, small for their gestational age, they can be full-term or preterm babies, and they have a birth weight below the 10th percentile. This chart shows very clearly the weeks of gestation and then baby's weight. A baby that is born to term is within this gray area. And then if their weight falls in this area below this 10th percentile line, they're considered small for their gestational age. Between the 10th and the 90th percentile, they're considered appropriate for their gestational age. And then above the 90th percentile, they're considered large for their gestational age. And then if we look up here at babies born preterm, and then we can also look for babies born post-term. Half of all small for gestational age births are attributed to a mother's illness, mother smoking during pregnancy, or mother's poor nutrition. Small for gestational age infants have a significantly higher risk of neonatal morbidity and mortality of being a stillborn. When a baby is born, they're going to look for physical and behavioral characteristics of all babies born, but they're going to look specifically closely for our babies that are born early or with a low birth weight. The Dubowitz or Ballard score is this test right here. This is used to estimate gestational age of a baby. Scoring of this must be completed within the first 24 hours after birth. So they're looking for two different categories of items. They're looking at neuromuscular maturity, so the baby's posture, how babies recoil their arms, how flexible babies are, and then they're given a score, as well as with physical maturity, looking at their skin, their planters, their foot surface, their eyes, and then they're taking these scores and they're adding them up, and then whatever the score is, they're able to estimate how old a baby is in their gestational age. If a baby's born early or with a low birth weight, there's some physical characteristics that they might have. They might have a fine hair all over their body. That's called langu. They might have smooth reddish skin. They could have abscess of skin folds or creases. They would have a lack of ear cartilage, and they would also have breast buds. Some behavioral characteristics that we would notice would be reduced muscle tone and activity, increased joint mobility, so their joints are able to bend more than they should. They may appear passive and have disorganized movements within the first week. The rate of preterm birth and infant mortality are at an all-time low. Preterm birth represents a minority of births, but it is responsible for most of the neonatal deaths and nearly 1/2 of all cases of neonatal onset neurodevelopmental disabilities. There are many different causes for a preterm birth. This is a really great infographic that kind of details that. Risk factors, potential risk factors down here. There are many complications that come when a baby is born early One of those areas is respiratory issues. So breathing problems for infants that are born before the 34-week mark result from having an immaturity of the lungs, and their body is not producing they're not producing this called surfactant, which is it helps the lungs work correctly. So something that can be developed is hyaline membrane disease. This is when this decreased production of surfactant that helps the exchange of oxygen and carbon dioxide. So that's the problem that's happening in this disease. If it is an uncomplicated case, it can usually resolve itself between 72 to 96 hours after birth. They can do surfactant replacement therapy for a baby to help them and their lungs get going. Babies might also be on supplemental oxygen or a CPAP machine. If a mother is going to be delivering early, having a preterm delivery, they can actually give steroids to the mother as an injection 24 to 36 hours before this preterm delivery. And those steroids will tell the baby to wake up its lungs and get that surfactant production going. This issue over here, bronchopulmonary dysplasia, is for infants who require supplemental oxygen or mechanical ventilation beyond 28 days postnatal age. So beyond 28 days since they are born, or at a corrected gestational age of 36 weeks. And they have atypical chest x-rays and atypical respiratory examinations. This is primarily seen in infants who are born at less than 32 weeks gestation. This is the most common chronic lung disease of infants in the U.S. And babies may continue to have lifelong problems, including a limited tolerance to physical activity, feeding difficulties. This might contribute to poor physical growth, having an increased risk of cerebral palsy, and other developmental disabilities. Also, looking at complications that occur neurologically, the complications that occur in a brain of a preterm baby are often linked to breathing problems. We're not getting enough oxygen to our brain. So we can have something that is called an intraventricular hemorrhage. This is when bleeding is occurring into the ventricle space within the brain hemisphere. If you look at this chart, it shows the different grades of this type of a hemorrhage, and the dark is represented as the bleeding that's happening in the brain. An ultrasound of the head is suggested for shortly after birth of all preterm infants that are born at less than 30 weeks gestation, with continued follow-up ultrasounds. Something else that can happen is a periventricular leukomalacia, and this is the most common form of cerebral white matter injury in preterm infants and results in cerebral palsy in 60 to 100% of the survivors. This occurs when the periventricular region sustains damage either due to low oxygen or low blood flow. And this is tested for using ultrasounds of the brain and MRIs. Babies that are born early are also at risk for auditory toxicity. This is an increased risk for hearing loss due to illnesses they might face, frequent use of medication, and the excessive environmental noise. Babies might also develop apnea or bradycardia, which is a respiratory pause, a breathing pause, that lasts 15 to 20 seconds with a decrease in heart rate to below 80 to 100 beats per minute. This is happening because there's an immaturity of the central nervous system. This is most commonly seen in babies born at less than 33 weeks gestational age. And it tells us that there is a physiological immaturity of the brain to control respiration. For babies that are born preterm, their bodies aren't quite ready to do everything that they need to do in order to help them survive independently without some medication or therapies, or even in this picture, you having a sleep apnea monitor or a sleep apnea belt. Something that happens in all types of infants, especially preterm infants, is sudden unexpected infant death syndrome. Now, this is different than SIDS, which you probably have heard of before. Sudden infant death syndrome is the umbrella with which SIDS is under. So this is the leading cause of post-neonatal mortality in the U.S. So it's the leading cause of death in our babies once they're born in the United States. 90% of these cases occur before 6 months, and it does occur more frequently in premature infants. Babies born early may also have issues and complications with their heart. So this problem detailed in this Cleveland Clinic picture has to do with the blood flow within the heart. So there's a vessel in our heart, which is kind of right here in this purple part, that diverts blood flow from the lungs. Now this closes at birth to allow blood flow to the lungs. So we want to make sure our lungs have good blood flow, but sometimes in babies born early, this does not close. So they can be born with an open vessel, and a doctor would do an echocardiography to look at that heart to diagnose, and you can manage this with medications, fluid restrictions, and a CPAP breathing machine. Babies may also have issues with their bellies and their gastrointestinal areas because the suck and swallow response is immature and it's poorly coordinated until approximately 32 to 34 weeks gestation. So babies born early will likely have tube feedings, maybe have special specific formulas with different nutritional needs. Necrotizing enterocolitis happens when there is an injury to a portion of the bowel wall in a baby. To solve this problem, they might withhold feedings, give some suction to the area to decrease that wall pressure, give antibiotics, and provide IV fluids and nutrition. Half of all the cases of this require surgery to remove a diseased section of the bowel. Babies born early might also develop GERD, which is when the contents of the stomach are regurgitated back into the esophagus. And this causes an increased risk of vomiting and aspiration pneumonia. And that GERD is what is detailed in this picture right here. Babies might also have issues with their eyes. They might also have retinopathy of prematurity, and this is an impairment in the retinal vascular development, which is in your eye, these vessels back here. The infants that are at highest risk are the ones that are born at less than 28 weeks gestation and weigh less than 1 kilogram at birth. Monitoring and preventative therapies can help this issue. Babies born early are also at an increased risk for infection for the first months of their life. Their immune system is not as built up as babies that are born at term. They may also develop some other type of physiological impairments with their body, issues with their blood, hypothermia, controlling their ability to control their body temperature. They might also have hypoglycemia or hyperglycemia, having difficulty their body controlling their blood glucose levels. There has been a lot of developments that have been made in the prevention of preterm births. It's very important that doctors provide education and prenatal health care. If we take good care of mothers during their pregnancy, they are less likely to have a preterm birth. And We can also, with good prenatal health care, detect if a preterm birth would be possible. And that is why sometimes mothers might get placed on bed rest, or they might be placed on bed rest at the hospital under watch of very, very specifically trained doctors who can help prevent a preterm labor and let that baby keep growing and working on everything it needs to do inside of a mother before a preterm birth is necessary. The best is having care in a high-risk OBGYN center with a children's hospital with NICUs. Since 2000, the neurodevelopmental impairments have decreased among extremely low birth weight infants. There's been a decreased risk of sepsis and less cranial ultrasound abnormalities. There has been no change in the rate of chronic lung disease. Thinking about the medical and developmental care of these babies, we need to create an optimal care environment in the NICU. So, individualized neurodevelopmental care has become the most successful form of treatment, and that involves actively involving the parents. So little babies in the NICU do better when their parents are able to be with them as much as possible, or they're able to have as much contact with adults as possible. So that's called kangaroo care, and this improves preterm growth, decrease hospital-acquired infections, and it can possibly shorten the hospital stay. And kangaroo care is when we can place the baby on the chest of a parent, and they can get all that good care that way. There is improved functioning of a neonate in the NICU. So our babies that are in the NICU will have a reduced number of apnea events, faster weight gain, improved oxygen, good improved motor maturity, and behavioral state organization when we can take care of them in good NICUs. Usually, if a baby is in a NICU, they will have a care team and a care plan. That includes people like a physical therapist, an occupational therapist, a speech and language pathologist, a developmental psychologist, and a developmental pediatrician. And they will guide the care based on the needs of the baby and the family. A possible referral to an early intervention program in the community can be something, if it's beneficial to the family, and it would be beneficial to the baby, that's something that can be provided. We are very fortunate to live around many, many good NICUs. NICUs are rated in terms of level, and the higher the number, the better the care, the better the services, the more resources they have. So Akron Children's is a level 4 NICU. And then if you're more in the Canton area, the Altman Hospital in downtown Canton has a level 3 NICU. So after a NICU stay, there's a lot to consider. One of them being the medical cost, length of the stay. It can get very costly for a baby to be in the NICU for an extended amount of time. But there is clinical criteria for when a patient can be discharged. They must have medical stability, and they must continue to grow at home. They have to be able to feed well by the mouth. They have to be gaining weight. They have to be able to maintain a stable body temperature and have no episodes of apnea or bradycardia, that's that pause and lapse in your breathing. Usually this happens for babies who are low birth weight, between 35 to 37 weeks of gestation after they're born. So in extremely low birth weight infants, that's between 37 to 42 weeks gestational age post-birth. This chart is on page 76 of our textbook, table 5.1. This is improvement in survival rates of premature infants. And you can see that based on birth weight and looking across the years, the rate of survival has greatly increased for each category of birth weight. Families will need adequate support following discharge. Usually that will include close medical supervision, maybe home care visits by nurses. And this can also put a lot of stress on our parents. Taking care of a baby who might be a little more medically fragile, and also maybe bringing home a baby for the first time, but your baby has been born for 3 months. That's a huge change for a family and can present a lot of stress. So the intervention benefits for babies that are born early has been greatly debated, but the benefit of neurodevelopment in most premature infants through 3 to 5 years is pretty research-based. There's a statistically significant benefit for early intervention programs that is shown in full-scale IQ by the age of 5. So if babies who are born prematurely participate in early intervention programs, there's a likelihood that their full IQ scale level will be better than it could have been without intervention by 5 years old. So medical professionals will use corrected age until a baby is 12 to 24 months of chronological age. So finding corrected age is detailed here. Some early intervention programs can include group meetings for parents, home visits, attending a multidisciplinary child care developmental center with low teacher-to-infant ratio. Even with early intervention, many children may continue to need special education services like speech-language therapy, physical therapy, occupational therapy, special education, behavioral therapy, or treatment of emotional problems. The benefits of early intervention may be lost over time without a continuation of services. So by the time a preterm baby enters school, the developmental status of children who had births above 1,500 grams, which is about 3.3 pounds, it's not very different from full-term infants. Children with birth weights below that 3.3 pounds and less than 32 weeks gestational age at birth have an increased risk for developmental disabilities. Extremely low birth weight children are at greater risk of developing executive functioning deficits and may require ongoing neurophysiological follow-up, neuropsychological follow-ups throughout middle childhood. Children that are born premature have a greater risk for lower levels of social competence. They often may be less adaptable, have less regular in habits, less persistent, and more withdrawn. ADHD is more common in children who are born premature, as well as sleep disturbances, feeding difficulties, tantrums, or resistance to limit settings. Major developmental disabilities is found in 1/4 of children with an extremely low birth weight. So in summary, compared to full-term infants, low birth weight and very low birth weight infants are at greater risk in the newborn period for many problems that may lead to long-term complications. Physiological immaturity of the organ systems often leads to complications. Most infants recover from these complications without major long-term impact. Other problems may be associated with poor neurodevelopmental outcomes. With an increase in public awareness, improved prenatal care, and advanced neonatal intensive care, increased parent involvement, and access to early interventions, the outcome of premature and small for gestational age infants is very likely to continue to improve. That is all we have for this week's content. If you have any questions, please reach out to me.